Well, hello, everybody. Welcome back to another episode of HeartBrief. This is Joel Kahn, medical doctor, triple board certified preventive cardiologist, and your host to present some very exciting papers this week that I think will help educate you and may help with your patient management. Always the fun part of being a doctor is the medical management. So I am going to share screen and let's see how this all works. Uh, Excellent. All right, so we are dealing right now with an absolutely fascinating article that turns some current concern on its head. This is published in the American Heart Association's journal. The first author, Evan O'Keefe, is the son of the second author, James O'Keefe, a cardiologist in Kansas City, Missouri, that I had the honor to do fellowship with many, many moons ago. A great preventive cardiologist also. And this is a database meta-analysis study. The senior author, Bill Harris or William Harris, is one of the world's experts on omega-3, how to measure it, and clinical utility of omega-3. And of course, there's been concern that certainly prescription omega-3 and high dose prescription omega-3 may actually trigger atrial fibrillation in some situations. Would be people usually with coronary artery disease being treated with 4 grams a day of prescription omega-3. So these authors went to the famous UK Biobank, and not all, but many of the members of the UK Biobank team had measurements of omega-3 in their blood, the omega quant. There were 261,000 of them that had data on their omega-3 level, and they were followed over time. None of them had atrial fibrillation at the beginning of the period of study. They were followed for 13 years. A number of them did develop atrial fibrillation over that time as they got older. And what they found was that the higher the blood level of omega-3, the lower the incidence of atrial fibrillation over time, 31% lower in the biggest cohort. Their conclusions: higher circulating omega-3 levels were linked to reduced atrial fibrillation risk. Now, this was not a supplementation study. People might have a high omega-3 level from eating fish. People might have a high omega-3 level from taking supplements of a variety of kinds. People could be doing it all with diet, flaxseed, chia seeds, leafy greens, hemp hearts, walnuts, and other food sources of omega-3 beyond fish. But this is certainly interesting data that flies in the conflict or flies in the face of the conflict and the controversy about omega-3 and triggering of atrial fibrillation. Over time, there obviously, as the graph in yellow and blue show, the incidence of atrial fibrillation was higher with age. We all know that, whether that's hypertension or stiffening of the heart muscle. Now, figure two, which I think you can see on the screen, is perhaps one of the most interesting pictures showing that at very low levels of omega-3 intake during the day, there may be a risk of omega-3. And at very high levels in the blood and supplements, over 1,500 milligrams a day, there may be an uptick. But the sweet spot of EPA plus DHA intake, fish, seafood, and fish oil supplements may actually favor omega-3 having a prevention effect, a preventive effect on atrial fibrillation. So this is all very interesting stuff. What also comes up at times, and I think it's reassuring for those of you that do measure omega-3 blood levels, as I do in my patients, and strive to return them to normal if they're low, because so many people are omega-3 deficient when you start measuring it. It's very reassuring for those of us that do that, that we are not necessarily triggering uh, the onset of atrial fibrillation. Okay, so I am going to go over now to a very provocative and complex study published in Nature Metabolism, January 15th, 2026, published online. This was a combination of some animal data and human data on NAD plus, the nicotinamide adenine dinucleotide, a major supporter of energy and overall metabolism throughout the body and every cell. They make the point that with age and disease processes, we become deficient in NAD plus. And many people are supplementing based on current social media and some science and companies with products like NR, nicotinamide riboside, and NMN, nicotinamide mononucleotide. And of course, there's also niacin or nicotinic acid. So in this study, they did take humans, 65 of them, healthy, and for 14 days, they supplemented them with one of three NAD plus potential boosters, NR, NMN, and one called NAM. And they did find that NAD plus went up with two of the three, NR and NMN, nicotinamide riboside, and NMN. But they went really deep on the microbiome, and they identified that a lot of the boosting of NAD plus that came with these two supplements worked via the microbiome, where the bacteria were actually converting these supplements into NA, nicotinic acid, niacin. Some of these supplements are very expensive. NA, nicotinic acid, is extremely inexpensive. Controversial in the cardiology world. It is still a supplement I use to lower lipoprotein A and occasionally to lower cholesterol. It's a supplement that I honestly take every day, niacin or nicotinic acid. And now we know that through the microbiome, nicotinic acid does ultimately lead to NAD plus elevation, and that even the NR and NMN pathways of elevating NAD plus do involve in the microbiome conversion to nicotinic acid, a mechanism certainly confirmed in animals that needs to be confirmed in humans. So if you're into this field of discussing with your patients pathways of aging, pathways of longevity, it's pretty hard nowadays not to discuss NAD plus as one of the pathways. There are people injecting it intravenously and sub-Q, and I'm not supporting any of that, but I'm simply bringing it up as discussing with my patients what they're doing and what other practitioners are recommending. And now we have a little more understanding of the science of how this all works in the human body. And the last article that I would like to share with you today, you might call it a little more touchy-feely, but critically important. Here we go. Is an article in the Mayo Clinic Proceedings, again published. It's got a 2025 date. It was December 2025. First author, Nazanin Rajai. Interplay of social determinants of health and traditional risk factors in predictive cardiac aging. This is very interesting. The measurement was cardiac age done by using a EKG and an AI interpretation that is available at the Mayo Clinic that estimates cardiac age. And then they looked at traditional risk factors like cholesterol, diabetes, smoking, high blood pressure, family history. But they also looked at a series of measures of what is called social determinants of health. And what they identified is even after adjusting for all these traditional risk factors, two specific social determinants of health strongly related to accelerated cardiac aging. One was financial insecurity, financial concerns, financial resources. And the other one was food access, access to healthy food. That those two impacts, which are typically not asked in a cardiology visit, how are your finances? How much stress? Are you preparing for retirement? Do you have the means to retire? Are you going to work to drop? Things like that. And access to healthy grocery stores, healthy farmer markets, CSAs, and the rest are just not part of our normal questioning. And in this particular study, financial stress and access to healthy food was important. So, as they conclude in this study, we described the key contributors to cardiac aging as determined by novel technology using AI-ECG. Our three key findings were the interplay of social determinant of health was most influential in terms of cardiac aging when compared to traditional risk factors. Financial strain and food insecurity were the most impactful. And we showcase that social determinants of health, such as financial strain, housing, and physical inactivity, are robust predictors of survival, matching or even surpassing certain conventional mortality risk factors. So, as we strive to be better clinicians and ask the important questions and take care of our patients optimally, we now have a new arsenal of information to acquire, either by questionnaire or through questioning, one-on-one, and we can become better clinicians and hopefully help people deal with situations. Although some of these are just tough to deal with, and they got to be dealt with at a systemic level that individual clinician might have, challenges and the rest. So thank you for letting me share HeartBrief this week. Three very important articles. Be back next week with more. Lead a healthy life. Thank you, Joel Kahn.